I'm excited to kick off with some of the updates in limited stage small cell lung cancer. So I'm just going to start with this recommended treatment approach for our patients with limited stage disease. This is taken from the latest version of the NCCN guidelines. We really think about limited stage in two different categories. So we think about really limited stage or very early stage. These are patients with TNM stage in the 1 to 2A category, where you perform mediastinal staging and the patients are not found to have any mediastinal lymph node involvement. And assuming they are felt to have operable disease, they'll go ahead and undergo lobectomy with more extensive lymph node dissection and sampling. And routinely, these patients should be referred to see a medical oncologist to talk about adjuvant systemic therapy, usually with platinum etoposide. For any patients who are found to have positive mediastinal lymph nodes, they're in this other category of stage 2B through 3C disease, where the standard is definitive concurrent chemoradiation and now followed by consolidation durvalumab based upon the Adriatic study, which I'll be reviewing with you. For patients with poor performance status, where you're really concerned about their ability to get through concurrent therapy, you could offer sequential chemoradiation. So this brings us to the Adriatic study. So this was presented in the plenary session at ASCO in 2024. And what you can see is this is a phase 3 randomized, double-blind, placebo-controlled study involving patients with limited stage. So this is stages 1 through 3, with stages 1 and 2 patients being inoperable. Good performance status. These patients had to have not progressed after definitive chemoradiation, and prophylactic cranial irradiation was permitted prior to randomization. And as you can see here, there was actually randomization to one of 3 different treatment arms. So the first was durvalumab, the anti-PD-L1 antibody given IV every 4 weeks for 2 years versus placebo. But there was a third treatment arm that included tremelimumab, CTLA-4 inhibitor. But for the purposes of the ASCO discussion and the results that were revealed, it was really a comparison between durvalumab and placebo, where the dual primary endpoints were overall survival and progression-free survival. And this is the Kaplan-Meier curve for overall survival, showing clear separation of the curves in favor of patients receiving durvalumab compared to placebo. So median OS, 56 months in patients getting durvalumab compared to 33 months in the placebo arm, corresponding to a hazard ratio of 0.73. When an OS subgroup analysis was performed, you can see that really all the various subgroups benefited from consolidation durvalumab. So regardless of what platinum agent they received, whether they received once or twice daily radiation, whatever type of response they had to chemoradiation, or whether or not they had received prior PCI, all of these patients are benefiting from durvalumab compared to placebo. Progression-free survival was another dual primary endpoint, again, favoring patients getting durvalumab, median PFS 16.6 months in the durva arm, 9.2 months in the placebo arm. When we think about safety, of course, the toxicity that we worry most about is pneumonitis. You can see here radiation pneumonitis rates were similar between the 2 treatment arms. And then when we think about this other pneumonitis category, presumably the autoimmune pneumonitis, slightly higher rate of that in the durvalumab arm, 10.7% versus 6%. So based upon this encouraging data, in early December 2024, the FDA granted approval for durvalumab for our limited stage patients who have not progressed after chemoradiation. So this was really practice changing. There have been a number of other trials looking at immunotherapy and chemoradiation in our patients with limited stage disease. And I show you these 3 trials because the strategy here was a little bit different from Adriatic, where the immunotherapy was actually being given concurrently with chemoradiation and then continued as consolidation. And what we do now have are the results from the NRG LU005 study. So this was looking at another anti-PD-L1 antibody, atezolizumab. But again, in this study, it was given concurrently with chemoradiation and as consolidation. And unfortunately, this was a negative study. So these were the results presented at ASTRO in 2024. So this was a phase 3 trial involving over 500 patients, primarily in the US and Japan. You can see that these were limited stage patients with an ECOG performance status of 0, 1, or 2. Patients here received 1 pre-registration cycle of chemotherapy with platinum etoposide, after which time they were randomized with the start of cycle 2 to get either atezo added to chemoradiation or just standard chemoradiation. And you can see in the atezo arm, after completion of radiation, the atezo is continues as consolidation IV every 3 weeks for up to 1 year versus observation. And the primary endpoint was overall survival. And unfortunately, again, you're seeing overlap of the curves here, indicating really no benefit with adding atezolizumab to chemoradiation and then continuing it as consolidation. And similarly, PFS, no significant benefit here. And when we look at safety, you can see that grade 3, 4 immune-related adverse events were significantly higher in patients getting atezo added to chemoradiation compared to patients just getting chemoradiation. And then pneumonitis is, again, the toxicity that we worry most about. You are seeing slightly higher rate in patients getting atezo with chemoradiation, 4.9% versus 3.2%. But encouragingly, the rates were low overall. So this brings us now to the ASCO 2025 presentation of the Achilles trial. So this was a Norwegian study. It was phase 2, so much smaller number of patients compared to Adriatic. But here, atezo was given only as consolidation. So this study design was more similar to Adriatic, so different from NRG-LU005, where the atezo was given concurrently. So in this study, all patients received 4 cycles of platinum etoposide, with concurrent radiation, assuming no disease progression, randomized to 1 year of atezo, given IV every 3 weeks, or observation. And these were the results that were presented. So both PFS and OS were unfortunately negative for the atezo arm. And I would say this was somewhat of a surprise to a lot of us, especially on the heels of the Adriatic data that had just been presented a year prior. When you look at safety, you can see that any grade 3 to 4 adverse events were higher in patients getting consolidation atezolizumab, so 34% versus 20% in the observation arm. So a summary of this study: no PFS or OS benefit with adjuvant or consolidation atezo in limited stage patients who did not have disease progression after twice daily radiation. Again, in stark contrast to the Adriatic results, there were no concerning safety signals. It's important to point out that in this phase 2 Achilles study that all patients received twice daily radiation, and the majority of the patients received PCI in this trial. Contrast this to Adriatic, where only 30% of patients received twice daily radiation, and 50% had received PCI. And again, with the caveat of cross-trial comparisons, I'm just showing you the PFS data here from both Adriatic and Achilles. And you can see that the observation arm in Achilles performed quite well, 16 months with regard to PFS. And that was, I would say, on par with the PFS that was achieved in the durvalumab arm in Adriatic. So, I think we know that twice daily radiation and PCI can be associated with better outcomes, and may sort of explain why we're seeing the observation arm performing so well in Achilles. We do now have the Delphi 306 studies, which is looking at consolidation tarlatamab in limited stage. So we're going to talk a lot about tarlatamab in the next talk. So tarlatamab, as you know, is a bispecific T-cell engager targeting DLL3. It's been approved now in extensive stage small cell lung cancer in the relapse setting. We're now looking at bringing it up into the limited stage setting. So this is an international randomized double-blind placebo-controlled phase 3 trial, so involving patients with limited stage disease who've completed chemoradiation without disease progression, with randomization to tarlatamab IV every 2 weeks for a year versus placebo. One could argue that we should not be randomizing patients to placebo with the approval of durvalumab. Nonetheless, this is the study design here, and the primary endpoints are progression-free and overall survival. We also have the ongoing Maverick study, and I'm being told we should get results from this study soon. And this is really asking the question of the benefit of prophylactic cranial irradiation. A lot of the data that we have supporting PCI, particularly in limited stage patients where there does seem to be more benefit than in an extensive stage, really predates brain MRI surveillance. And so this is, I think, an important study looking at MRI brain surveillance alone versus MRI brain surveillance with PCI. So this is a randomized phase 3 trial. This study involves both limited and extensive stage patients, no prior brain metastases, and no brain mets on MRI after first-line therapy, with randomization to either PCI or no PCI, with brain MRI surveillance being performed in both treatment arms. And the primary endpoint here is overall survival, and this is a non-inferiority study design. There are a number of other ongoing trials in limited stage disease. You can see here the first trial is the KeyLink 013 study. I showed this earlier in the strategy of adding immunotherapy to concurrent chemoradiation and then continuing as consolidation. So in this study, it's pembro with concurrent chemoradiation, followed by pembro plus or minus the PARP inhibitor olaparib. So this is a phase 3 trial. Another study is serplulimab. It's another anti-PD-1 antibody with concurrent chemoradiation followed by a year of maintenance. I will say on the heels of the results from NRG-LU005, I'm a little bit less enthusiastic about this approach of giving IO concurrently with chemoradiation. Nonetheless, we'll await results from these studies. There's a phase 2 trial looking at pembro consolidation after chemoradiation. And then finally, there's a study looking at toripalimab, another anti-PD-1 antibody, plus or minus this humanized antibody that targets BTLA post-chemoradiation. So sort of novel strategies in that post-chemoradiation setting. This is a phase 3 ongoing study. So key takeaways for limited stage disease: Adriatic remains practice changing, supports consolidation durvalumab for 2 years after chemoradiation for our patients with limited stage disease. We're not yet seeing an added benefit to immunotherapy with concurrent chemoradiation, as I reviewed with you from the NRG LU005 study. I think the role of PCI remains controversial, and we await the results from the Maverick study. And there are ongoing studies of novel consolidative treatment strategies that are underway, and hopefully we'll see results from those in the upcoming years.